Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Welcome to Behind the Knife. Today we're doing a journal review in burn fluid resuscitation. This is our first burn dedicated episode with our new burn team, and we're excited. So you're on call at a level 1 trauma center, and you get called that you're receiving a large TBSA burn patient. You're not working at a burn center. You remember hearing about some controversy surrounding burn resuscitation. Was it the Parkland formula? Consensus formula? You think you remember that ABSITE asked about the Modified Brooke Formula. So join Dr. Kathleen Romanowski, Dr. Laura Johnson, myself, and Dr. Lauren Nosanov to discuss modern burn fluid resuscitation. So, welcome, ladies. I thought we'd get started today with this case. You have a 35-year-old male who presents to the trauma bay of your level 1 trauma center after a welding accident during which his clothing caught fire. EMS reports the patient has sustained a 40 to 60% TBSA burn, total body surface area. Vital signs are heart rate of 130, blood pressure 150 over 96, SAT of 92% on 2 liters nasal cannula. Dr. Nosanov, what are your first thoughts?
So I have a lot of first thoughts, but the first thing I really want to know is, was there associated trauma? Was he in an enclosed space?
Why do you ask?
Well, whether or not the patient has associated trauma totally changes my course of management. Trauma is always going to come first. Burn patients are first a trauma patient, and I'm not just saying that because we're not in a burn center.
I always tell the residents that very few people on fire stand still.
Okay. But if no known trauma, I'm worried about the airway next. So following ATLS guidelines,
the patient is on 2 liters nasal cannula. On the monitor, his SAT is 98%. There's no soot in the mouth. He's speaking in full sentences. There's no stridor. He has no central facial burns.
Okay, well, that's reassuring. And B, breathing. Do I have clear and equal breath sounds?
Yes, you do. Dr. Romanowski, what next?
Well, next we move on to C is for cookie. Wait, no. Circulation. And this is where burns get interesting.
Also,
Burns are always interesting.
Very true. Well, so burn patients don't always have the best places to put IVs, and every burn patient with a significant burn requires 2 large bore IVs.
So can you place those IVs through burn injured skin? And what if your nurses can't get IV access?
So I always say place an IV wherever you have to place an IV. If it goes through a burn, that's just fine. Will it stay through the burn once it gets to the burn center? Probably not, but it could save someone's life in the transport process. And if you can't get an IV in, go for either an IO or a central line.
Anything else for C that you're worried about?
Of course, I'm a burn surgeon. So I always worry about circumferential injuries. Burns that are 3rd degree and go all the way around an extremity could lead to compartment syndrome. And then I also want to start thinking about how we're going to start our initial fluid rate for resuscitation.
So the patient has no circumferential 3rd degree extremity burns, no sclerotomy needed. The radial and pedal pulses are palpable and equal bilaterally. Now, what do you mean by initial fluid rate?
So burn surgeons love math, but we usually have to pace ourselves with initiating that math after we've already finished the primary survey. So advanced burn life support guidelines put out by the ABA recommend that the initial fluid rate in adult patients be started at 500 cc's an hour. Burn patients don't do really well with boluses, so we need an initial fluid rate that we can start a patient on so that we don't have to play too much catch up after we've started the fun math.
So why LR? You mentioned LR. Why LR? What about normal saline, plasmolite, other isotonic fluids?
It's a great question. So it's really actually goes back to basic chemistry. Our burn patients get tons of fluid over the course of their early resuscitation. So the problem with normal saline is that it isn't really normal. It's acidic. And if they get a large volume of resuscitation with it, burn patients will end up with a hyperchloremic metabolic acidosis in addition to any other acidosis they might have from their burn shock. Unfortunately, some of the other resuscitation fluids on the market, Plasmolite, for example, haven't really been extensively studied. So we can't say for sure that they're any better or worse than LR. And so recommendations are still lactated rares.
Dr. Romanowski, you take care of a lot of pediatric patients at Shriners. Would you start the pediatric patients on 500 an hour of LR also?
No, I mean, as we all learned on our pediatric rotation, kids are not just little adults. So you would start teenagers on that. So kids who are 13 and older would get 500 an hour. School-age children get 250 an hour of LR, and younger kids get 125 milliliters per hour of LR.
All right, just making sure. Anything else for C, guys?
So don't forget, we definitely need to start a Foley catheter to monitor hourly urine output. It is the gold standard of burn resuscitation.
Oh, pun intended. I love it.
Okay, your nurse places the Foley catheter successfully. Now, since we finished C, I'm guessing D.
Yes, D. We need to assess the motor and sensory components of our patient's extremities and determine a GCS, which is actually extra important when we have patients coming in after electrical injuries because the risk for spinal trauma is definitely a component of their overall trauma complex.
So GCS is 15, motor sensory intact, and all 4 extremities.
Then it's time to expose them. E for exposure. We need to see every part of the patient, evaluate the size of the burn, remove any jewelry or clothing that could cause circumferential tourniquet effect as they swell over the first couple days. As we do this, we're going to make sure to roll our patient and protect the spine because we haven't finished our trauma workup yet. And then after we're done exposing them, we need to de-expose them and cover them back up. Warm burn patients are happy burn patients. And if you have the opportunity to preheat your trauma bay, if you know a big burn's coming in, that would be amazing. Certainly, we try and get our individual patient rooms in the burn unit heated up as hot as we can tolerate for our patients when they are coming up to the ICU.
Okay, so you evaluate the burns and you note that the entire torso is burned. The central posterior torso is burned. So entire anterior torso burned. The central posterior torso is burned. The posterior right thigh and leg. The anterior left thigh and leg. The posterior left arm. The anterior right arm. And the neck. And I won't try to trick you. These are all 2nd and 3rd degree burns. As we know, 1st degree burns are not included in our total body surface area calculation.
Oh, you're going to make this difficult for me. This is what I get for saying burn surgeons love math, huh? So we're going to do the rule of 9s. That's how I usually start for a rough estimate to calculate the burn size in an adult. Dr. Miles, you better have a calculator because I do not have one in front of me.
Calculate for you.
Love it. So the anterior torso is going to be 9 plus 9 for the chest wall and then the abdomen combined. So that should be 18. The central posterior torso, we'll say, is about 7. The posterior lower extremity, right thigh and leg in combination is going to be 9. And so is the anterior of the opposite leg, anterior thigh and leg will be 9. The anterior of the left upper extremity is going to be 4.5. Arms have less surface area overall than lower extremities, so they get no more than 9 total. And the same for the posterior of the other arm. And then the neck, we're going to say about 2%. And you said the face was not involved, so I think that's where the math stops.
Yeah, face not involved. So from your math, we're at 54%. I will say there's also an app for that. It's free. I use it to quickly calculate burn size in the trauma bay. It's called Burn Area. And no, I don't get paid for saying that. In smaller burns, you could also use the Palmer method, though I teach it as the Hander method. Your hand is your 1%. A 6-year-old's hand is their 1%, not your hand. So you can either march out what is burned, or in larger burns, you can march out what isn't. So you do all of this math, and then what, Dr. Romanowski? A 54% burn.
So now it's time to calculate their adjusted fluid rate. The ABA has a consensus formula. and it's what also is taught in ABLS, which recommends 2 milliliters per kilogram per percent total body surface area burned for adults. And this is to be given over 24 hours. You give the first half over 8 hours in theory, and the second half over the next 16 hours. So how much does this patient weigh?
Let's just say 100 kilos.
Oh, good. More math. As Dr. Johnson said, burn surgeons do love math. So 2 times 100 times 54 divided by 2 and then divided by 8 will give you our initial adjusted fluid rate.
All right, so our adjusted fluid rate is 675 cc's per hour of LR.
Sounds right to me.
Wait a second. Dr. Romanowski, you and I have had this conversation before. Is that what you guys really do at Davis?
Well, no. Actually, we use the Parkland formula. However, for the sake of the ABSITE and for ABLS, this is the answer. In 2008, the American Burn Association published a set of practice guidelines that laid the groundwork for how we were going to manage burn shock resuscitation today. This patient emphasized that while formulas like Parkland, Consensus, Modified Brooke help estimate initial fluid needs, resuscitation is a very dynamic process. It's not like, I tell my residents, it's not like an oven. You don't set it at a temperature and leave it there. You change it continuously. So the authors of this paper advocated for ongoing hourly titration based on physiologic endpoints. And in particular, what they used is urine output. The goal was to avoid both under-resuscitation and the dreaded fluid creep of over-resuscitation. They also stressed the importance of early IV access, using lactated ringers as your crystalloid, and cautioned against excessive bolusing. The bottom line, these are guidelines, right? And this pushed burn care towards individualized responsive fluid management, not a particular formulaic math equation.
Right. So no perfect formula for every patient. Dr. Johnson and I use 2 from the consensus formula. What about you, Dr. Miles?
2 also.
Yeah, so as you can see here, as we all know, there's a lot of controversy around burn resuscitation formulas. At the end of the day, the adjusted fluid rate is just a starting point. You just look at it for that first hour. I don't think anyone in any burn unit across the country is not titrating fluids hourly. We should record the urine output for the next hour, and if we overshoot our urine output goal, we decrease the fluids by 10%. If we overshoot, we increase by 10%. And if you've overshot or undershot by a lot, you can sometimes go up or down by 20%.
A recent 2023 study by Rizzo looked at how the initial formula choice affects total fluid volume over the first 24 hours after a severe burn. They found that patients resuscitated with higher volume formulas like 4 cc's per kg TBSA, the Parkland formula, ended up receiving significantly more fluid than those treated with more conservative formulas like the ABA's 2 cc's per kg per percent TBSA. Really, the take-home message was the higher you start, the more you give, regardless of whether the patient actually needs it per se. This supports the shift towards lower initial volumes and more aggressive hourly titration, reinforcing the idea that the formula is just a starting point, not a destination. So with that, what is your urine output goal?
So that I think we all agree on, although I will say I think burn surgeons, the only thing we like more than math is arguing basic concepts. But we're going to say 0.5 cc's per kilo per hour in adults and 1 cc per kilo per hour in our pediatric patients. Greater than 1 cc per kilo per hour in adults with electrical injury. I think we all do agree, though, that bolusing the patient is not the answer.
Agree. Yep. So you only use the urine output to titrate your fluids?
Nope.
I didn't think so. So what else do you use?
So there are a lot of different things you can use. Many surgeons use serial laboratory values such as lactate or base deficit, but you can also use vital signs and physical exam to inform your decision making.
Sounds reasonable, but I think for the purpose of this podcast, we would say urine output is the gold standard.
Ooh, you did it again.
Agreed. both that urine output is a gold standard and a great pun. Sadly, there haven't really been large studies looking at other methods, so we're still waiting to see if something will surpass the gold standard.
Hey, Behind the Knife listeners, it's Kevin here. Do you dread doing your notes at the end of clinic? Do you feel like you can never get ahead of charting? If you are shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. Written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Freed learns your style over time, just like a human scribe, and it will never quit on you. Freed is used by over 6,000 clinicians from every specialty. Give Freed AI a shot to help you with your clinic. BTK listeners get 50% off their first month with code BTK50. That's BTK50. Now back to the show.
All right. So your turn, Miles. The last time, 2 hours, your interns have called you and said the patient made less than 10 cc's of urine for each hour. So what are you going to do?
So I would consider the C's of resuscitation failure.
Enlighten me.
Okay, so I have to give Dr. Steve Kahn at MUSC and my burn director in New Orleans, Dr. Jeff Carter, the credit for these, although I have added a few. I initially learned the C's in an advanced burn provider course when I was a PGY2 in Miami at the Southern Region Burn Conference. So the first C's refer to complications of inhalation injury, carbon monoxide or cyanide toxicity. So you're considering an inhalation injury. Next, concomitant trauma. So sometimes I do a fast, a repeat fast, or review the patient's initial scans. Was there missed trauma? I consider comorbid conditions. Does the patient have unknown CHF or CKD or end-stage renal disease? I'll scour EPIC, under care everywhere. The calculation error, that's pretty self-explanatory. Compartment syndrome. Sometimes a missed need for escharotomy or an incomplete escharotomy can cause low urine output. And then now for the two I've added. The patient can't pee. Is the Foley clogged? Again, consider AKI, end-stage renal disease, CKD. We now know that with cyanokit administration, especially 2 doses, we can see early and severe AKI in some patients. And then lastly, cocaine or other drugs, especially methamphetamine. So I review the tox screen.
I love these. I think this beautifully encapsulates all the problems we potentially run across in that early phase of burn patient management. But your patient is still not making any urine. So what's next?
So now we're going to go real controversial.
I would add fresh frozen plasma. At our institution, we order immediate release 4 units of FFP, but where I trained in fellowship at Parkland Hospital, we used 5% albumin. We would start LR for the next hour at 50% of our goal rate and 5% albumin at 50% of our goal rate. We know burn patients are losing protein as the endothelium is no longer intact. FFP can be magic for burn patients, and some studies show that it restores the glycocalyx. Are you guys FFP or 5% albumin users? I know there's a head-to-head trial going on right now regarding this topic. No right answer.
Right. So Dr. Johnson and I use FFP at Grady, though we do consider albumin if we think the patient has known liver dysfunction.
And at Davis and at Shriners, we use 5% albumin. However, we don't usually start it until patients are at least 8 hours out from their injury.
So colloid protocols obviously differ even more than burn resuscitation protocols. And research is ongoing, but I think the burn surgeon community is in agreement that colloid, whether it be 5% albumin or FFP, is the rescue in burn patients failing resuscitation. Now, I have another one for you, and this one's realistic. We faced this year, actually. A major IV fluid plant suffers damage from a hurricane and your hospital does not have access to IV fluids. What do you do? Whether you're in the US or in austere environments.
Yeah, this was a really scary situation as we really thought to think about what we were going to do if we ran out of IV fluids entirely, and even start to think about which patients would get them. But one thing that's being looked at now is oral rehydration formulas for larger burn sizes. Maybe not the massive ones, but definitely larger than what we would normally consider orally fluid hydrating someone. There are World Health Organization published guidelines that help account for these scenarios.
I know at our institution, we're enrolling patients in Dr. Jeffrey Shup's trial out of MedStar that's looking at outcomes in resuscitating non-massive TBSA burn patients with an oral rehydration solution. So I think overall more to come, but certainly this year highlighted for us in the burn world the need to investigate alternatives.
And don't forget, there have been some other interventions studied over the years to decrease the amount of crystalloid patients get. Those include vitamin C, plasmapheresis out of the Washington group, and early CRRT, again, to try and address the inflammatory burden in these patients. And these may also offer alternatives, though maybe less in austere environments than in the US.
More things to argue about in the future.
So I think we're out of time, but I want to thank you all for tuning into this episode of Behind the Knife with your new burn team. We've had a lot of fun putting this episode together for you and look forward to producing more high-yield burn podcasts for you in the future. Please feel free to send any topic ideas our way. And with that, go resuscitate those burn patients and dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.